Hello? All right. Hi, my name's Drew Kocher. I'm a Cardiology Fellow here, and I'll be helping to moderate today's session. Because of how successful last week's session was on ACC Latebreakers, we're doing a part 2 with a really all-star cast of presenters today. So I have the privilege of presenting our first speaker, Dr. Adam DeVore, who's a rising star in the heart failure world. Dr. DeVore is an assistant professor of medicine here at Duke, and it's at Duke where he also completed his training in cardiology and advanced heart failure fellowships. He came to us by the way of the Brigham and Women's Hospital, and prior to that he completed his medical school at the University of Chicago. Dr. DeVore is leading several national and international trials and clinical registries in the heart failure space, including CONNECT-HF, Pioneer, and AHA's Get With the Guidelines Heart Failure Registry. And it's from this registry that Dr. DeVore will be presenting one of the ACC Latebreakers today.
Thank you. That was very nice. My mom's not that nice to me. That was pretty nice. Let me go back one slide here. So I have the privilege of presenting this on behalf of Amberesh Pandey, who was a young investigator at UT Southwestern who presented this as a late breaker at ACC. And I told him we were going to have this forum and the opportunity to get to share some of the results back here at the DCRI. And he asked that I start off with a thank you. He's done a number of analyses with Get With the Guidelines. As many of you know, we've been the Analytics Center for Get With the Guidelines for over 10 years now. And he's had a Young Investigator Award. He's worked with us on a couple of different projects, and he just had nothing but superlatives to say about his experience with that and working with the statistical team. So I thought I'd start the talk by saying thank you on behalf of Amberesh for all of the Get With the Guidelines folks that worked on this project and the many other ones that we're doing. I see many of you guys in the back. So nice work and thank you. So the title of this talk is around looking at risk standardized mortality rates and the association with long-term outcomes for patients. And to do this, I really need to kind of give you a little bit of background and tell you why this is relevant. So shown here are a couple recent policy initiatives by CMS, or the Center for Medicare and Medicaid. And the focus of all of these policies is to try to reduce 30-day readmissions for heart failure and try to improve the overall quality of care that patients are receiving. And the two that I want you to focus on are the one in the middle. So in 2012, CMS started penalizing hospitals with higher than expected readmission rates for heart failure. And then the focus of today's talk, there's also a program that penalizes hospitals with higher than expected mortality rates for heart failure. But importantly, shown in this figure is that there's really an emphasis on trying to prevent 30-day readmissions more than mortality. So we're going to talk a little bit more about mortality today. But shown in the scales here is that the current incentives really favor readmission prevention over mortality reduction. But also relevant is that there have been a couple of studies, some of them done here at the DCRI, that show that if you try to classify hospitals by their 30-day heart failure readmission rate, there's actually not a very good association with the type of care that they provide for patients. And there's also no association with the long-term outcomes for the patients. And so these have been challenged recently. Are these really a good metric for describing hospitals? And that's where the idea of using mortality rates may be more helpful. So with that in mind, the objective of this study was to look at the association between hospital performance on risk standardized mortality rates and long-term outcomes for patients admitted with heart failure. And to do this, we used data from Get With the Guidelines registry linked to Medicare claims. And as you can see, we included over 100,000 patients from 300 hospitals in the US. And the study period were patients that were hospitalized between 2005 and 13, and we had 1 year of follow-up through 2014. The main variable of interest here is the risk standardized mortality rate. This has been used a couple of times in different analyses, but you can see the formula shown here. So we use patient variables to help calculate a risk model, and then you look at the predicted versus the expected death rate for the hospitals over 30 days and multiplied by the average mortality rate over the study period. And our main outcomes shown here are 5-year mortality rates. So I hope this projects well. This is trying to classify the different groups of hospitals in different quartiles by their risk standardized mortality rate. So in the green are the high performing hospitals, those with the best mortality rate. And you can see their 30-day risk standardized mortality rate is 8.6%. There's a nice gradation here, and those in the low-performing hospitals had a 30-day risk standardized mortality rate of 10.7%, so a 2.1% absolute difference across 30-day mortality rates here. And I'm going to show you a couple of different types of outcomes here. So one are, I'll show you the observed mortality rates. And then I'm also going to show you adjusted results as well as a landmark analysis where we only considered patients who survived the first 30 days since we're describing hospitals by their 30-day mortality rate. And these are some of the hospital characteristics. These are just a few that I selected out here. If you look on the left are the high-performing hospitals, and on the column on the right are the low-performing hospitals. And there are some differences between the hospitals, so this is important. Hospitals that were in the high-performing group were more likely to have PCI capability, more likely to have cardiac surgery, and more likely to be a heart transplant center. So the hospitals are a bit different when you look across the different groups. I didn't include it here in the interest of time, but we also looked at differences for patient characteristics, and there actually aren't very many differences in patient characteristics across these different hospitals. And then this actually becomes a really relevant slide. If you remember back at the beginning, I told you if you classify hospitals by their readmission rate, you don't see much differences in the care they receive. But this is describing the care that the patients receive when you describe them by mortality rates. So again, on the left are the high-performing hospitals, and on the right are the low-performing hospitals. And we don't see very meaningful differences in terms of medication use, but you do see a lot of differences in transitional care. That's the third row here, a post-discharge heart failure follow-up. A pretty good marker of what's happening with the patient when they're discharged from the hospital and their first follow-up visit. And you can see there's a pretty big difference across the hospitals here. We also saw that hospitals in the high-performing group were more likely to get defibrillator therapy as well as cardiac resynchronization therapy. So some differences in the care the patients are being discharged with. And then these are the outcomes that we looked at, all long-term survival rates. So the two rows across the top are the overall population, and the two rows across the bottom are the landmark analysis with those that survived the first 30 days. As you can see, the survival is much better in the high-performing hospitals, a median of 717 days compared with 579 days in the low-performing, and then a much higher 5-year mortality rate. You then see a very similar result when you look at the only including patients who survived the first 30 days. So overall, better survival here. And then I really like this figure. These are forest plots that look at the adjusted hazard ratios, and you see a really nice inverse graded relationship between the high-performing hospitals and the risk of 5-year mortality here. On the left side of the screen are the overall results, and on the right side are those that survived the first 30 days. So I think this has some really important implications, kind of returning back to the beginning. First of all, if you look at the high-performing hospitals on 30-day risk standardized mortality rates, you saw that they're more likely to get guideline-directed heart failure care. They're also more likely to have better long-term survival. And the reason we think this is helpful is with all of the criticism of the readmission metric, it seems like this might be an alternative to use here that is both measurable for hospitals and actionable for hospitals. Again, I want to say thank you to the Get With The Guidelines teams that worked on this. This is published in JAMA Cardiology. If you'd like to see the full manuscript, we have a couple other analyses that are relevant there. All right, that's the end of my presentation. If you guys want, I can take questions now. Audrey, do you, okay?
Yeah, that would be great. I have a quick question for you, Adam. You alluded to some of the criticism that the 30-day readmission policy that CMS has imposed. Do you think based on the work that you've done and other work that's come out that we should reconsider that as a metric to penalize hospitals? And would you use 30-day mortality instead of that?
Yeah, I mean, that's kind of what I'm hinting at here. I think this is a nice alternative to it. So just to give you a little more thorough answer, so some of the concerns around the readmission policy is that it does seem like it really had an impact on hospital behavior. If you meet with hospitals around the country, people definitely have responded to this. Despite that, we can't really see any evidence that it is a good metric to be using. The other very concerning finding is that if you look at the time period of which the readmission metric was implemented, there's actually an uptick in mortality for heart failure patients. And so it's pretty concerning that this may have not been the right policy from the beginning. I think the problem now is that when it was implemented nationwide. And I don't think I have to convince this room that if we would have done this in a little bit more of a rational study design, we could have actually tested, is this a good policy or not? And so now we're kind of left with the fact that every hospital in America does it. And we can do some pre and post temporal analyses, but there are challenges with interpreting those. So to answer your question, I think this is a good alternative, but before we'd really kind of leap into that, I'd want to see some other analyses here. And if you're going to roll that out, I'd want you to do it in a well thought out study design. But I think the people in this room would support that. So, yes.
So Adam, I think it is a problem either way, whether you look at readmission or the adjusted mortality as you have done. Because one of the things that, we did look at this many years ago with Eric from one of the data sets. One of the issues with any adjustment you have, it doesn't account for the operational issues that, the finances that the institution have to look after all these quality of care indicators, the education level of the patients that come to you versus the people that go to this high mortality hospitals. And all of this has a big bearing on the outcomes of the patient. So insurance level, for example, all these have to be accounted for, because what you are doing by doing this and showing that this adjusted mortality is high, they are being penalized 3% of the fees, and they are making them even worse as far as the operational. They are not able to keep and retain people that are looking after all this stuff. I can tell you from my own experience in a small community hospital where we are facing this challenge every day, when you're being penalized for readmission, when the guy just walks out from a heart failure admission, stops at Kentucky Fried Chicken, eats that, and comes back with heart failure in less than a day. So I think these kind of analysis are only hurting people, the hospitals that are low volume, in my opinion.
Yeah, I think you make a good point. And so, if you return back to the first couple of slides, the goal here is that we know heart failure care is not perfect, and so we're trying to make it better. And I think your story illustrates what I said earlier, that I think hospitals have responded to this. The financial penalty doesn't sound like a big percentage, but it's often the difference in the margin for a lot of hospitals. And so I think there has been I see Linda here, she's heard me say this multiple times, kind of an overreaction to this penalty where everyone's kind of hyper-focused on this transitional care at the time of discharge. And so I agree with you that it's a problem. I think the 30-day mortality data is more reassuring. If you wanted to compare models to each other, the performance of the mortality model in heart failure is much better than a readmission model across the board, regardless of the data set you're using. And so I think if you were going to try to have a policy like this, I think this is more rational than the 30-day readmission. But I think you're right that people have responded to this, and sometimes there are unintended consequences of it.
What I'm requesting is that it should be adjusted for patient mix, the insurance status, the education levels, et cetera, et cetera.
Yeah. So, we're able to do that because we use registry data here, but you're right. If you were to roll this out nationwide, you'd be limited to Medicare claims, and it's not quite as good. Yes?
Was Duke included, and are you allowed to talk about how we perform?
No, I can. So one of the things at the very beginning, I mentioned that in 2009, CMS, one of the first policies they had was around public reporting of readmission and mortality rates. And so Duke is on there, and you can look at how Duke performs for 30-day heart failure readmissions and mortality rates. And it doesn't report the number, it reports if you're higher or lower than expected, and we perform as expected in both of those. Is Duke a Get With the Guidelines site? Yes, it is, and so it would have been included in the analysis, but I don't know specifically how they contributed here. But those data are publicly available. Now be careful, I was rounding this morning, so I don't too personal here. I did readmit somebody this morning who was discharged last week, so. Any other questions? Yes, go ahead.
Can you talk a little bit more about what you mean, like the main differences is what between high performing and low performing is what happened in transitional care?
Yeah. Let me see if I can go backwards without making everyone dizzy. So in the manuscript, we have, the registry is great at quantifying the quality of care provided at the hospitals. And so we have more of this in the manuscript than we do here. But the main one we were talking about here is the post-discharge heart failure follow-up. So this is, in the registry, is coded as having a planned outpatient clinic appointment within 7 to 14 days of hospital discharge. It's not the only component of transitional care, but it's a pretty good one. And I think these differences are pretty striking. These aren't subtle differences. And so that's what I meant by the difference in transitional care. We have some other metrics in there, including the manuscript. Okay. Well, thank you for the questions. I'm going to stick around if there are questions at the end, but I think I'm going to pass this on to Alex. Sorry. Here, I'll give this to Alex. You can say some glowing things
So
about
I have the privilege of now introducing Dr. Fanaroff, who is one of our stellar DCRI Fellows here. He's actually serving as the DCRI Chief Fellow this year. He's been a Duke lifer, came here for undergrad, is a huge Duke basketball fan, stayed on for medical school here as well as internal medicine residency, and is in the midst of his cardiology fellowship. Will actually be staying on next year to complete an interventional year as well. He's passionate about acute coronary syndrome and hospital systems of care, and will be presenting to us about undetermined causes of death amongst cardiometabolic trials.
So thanks, Audrey, and thank you guys for being here. So like Adam, I also have a thank you. This is work that the Duke CEC has done a lot of working, especially with Renato Lopez. So thank you to all of you guys that work on CECs and have made a lot of this work possible. So this is I present this as a poster at ACC, and I've converted it into slides for your all's benefit. So modern cardiometabolic clinical trials incorporate cardiovascular mortality as a component of their primary endpoint. And what that means is that we have to do a CEC, event adjudication, to determine cause of death. But sometimes cause of death can't be determined from the records that we have. Sometimes all we get is patient died. And deaths of undetermined cause are conventionally assumed to be cardiovascular deaths for the purposes of the primary statistical analysis of these clinical trials. But the proportion of deaths due to undetermined causes are infrequently reported in primary trial manuscripts. And this recently became pretty important because of the publication of this document about cardiovascular stroke endpoint definition for clinical trials that the Standardized Data Collection for Cardiovascular Trials Initiative put out, featuring a bunch of people from CECs around the country and around the world, and also folks from the FDA. And one passage that I think that I wanted to highlight for you guys is that it says deaths of undetermined cause should be very few and should be assigned only when a death cannot be attributed to a CV or non-CV cause due to an extreme deficiency of information. Use of this category is discouraged and should be rare in well-run clinical trials in which adequate source documentation is assiduously sought by participating investigators. And I think that this raises the question, what does rare mean? How rare should it be? How few should they be? And I think that hasn't been adequately answered. There are no series describing the proportion of deaths due to undetermined causes across clinical trials. And as I said, most clinical trials don't report this data at all. They just report CV and non-CV deaths. So our objectives here were to pull data from DCRI, from clinical trials where the CEC was done by the DCRI, to look at the proportion of deaths of undetermined cause to kind of set a baseline for what very few means in well-run clinical trials in which cause of death is assiduously sought, and to identify baseline patient and trial characteristics associated with undetermined cause of death. So to do this, we combined data from 9 global cardiometabolic trials with CECs run by the DCRI and that had blinded central endpoint adjudication and blinded cause of death adjudication. And the trials came from 4 therapeutic areas: acute coronary syndromes, diabetes mellitus and prediabetes, atrial fibrillation, and stable atherosclerotic disease, coronary artery disease, and peripheral arterial disease. We pooled data from these trials and then calculated the proportion of deaths due to undetermined cause by therapeutic area, region of patient enrollment, as well as year of trial publication. And then we used multivariable modeling to identify patient and trial variables that were associated with undetermined cause of death amongst patients that died. So I think this is kind of one of the key slides here. So across 9 trials, we had over 127,000 patients and 9,273 deaths. 54% of them were due to cardiovascular causes, 30% due to non-cardiovascular causes, and 15.7%, or almost 16% of these deaths across 9 trials in which cause of death information was assiduously sought were due to undetermined causes. So when we looked at this by therapeutic area, to orient you here, this is a graph showing the proportion of deaths due to CV, which are the red bars, non-CV, which are the red and blue hatched bars, and undetermined cause of death, which are the white bars. And what you can see looking at undetermined cause of death, it ranged from 12.5% in our acute coronary syndromes trials up to 20% in our stable atherosclerotic disease trials. The diabetes trials, 16% of deaths were due to undetermined causes, and for the AFib trials, 14% were due to undetermined causes. The other striking thing about this slide is the proportion of deaths that are due to non-cardiovascular causes. So that ranged from almost 40% in our diabetes trials to less than 20% in our acute coronary syndrome trials. And all of these are trials ostensibly involving patients that are high risk for cardiovascular events and cardiovascular death. So substantial differences between these. And actually, if you look in the diabetes and our stable atherosclerosis trials, the majority of deaths were either due to non-cardiovascular or undetermined causes. When we looked at this by region, again, this is a similar slide with cardiovascular deaths in red, non-cardiovascular deaths in the red and blue hatches, and undetermined deaths in white. You see substantial variability in the proportion of undetermined deaths by region, ranging from 10% in Australia, Oceania, and South Africa to 18.5% in East and South Asia. When we look at the places where most patients were enrolled, Europe and North America, we see that there was a little bit less variability, but it still ranged from 17% in North America, 16% in Eastern Europe, and 13% in Western Europe. Lastly, when we look at the cause of death by publication year, we see that undetermined cause of death actually has increased over time, which is not what we really expected to see. It was about 9% in our trials published between 2009 and 2010, and going up to 20% in our trials published between 2013 to 2017. When we looked at patient characteristics by cause of death, again, this chart shows patients with undetermined death versus what we call determined death, so cardiovascular or non-cardiovascular death. We see that the patients' ages are similar, median age is 71 in both groups. More patients that had undetermined death, 32% versus 29%, were of female sex. Prior MI, heart failure, and cancer were similar between the two groups, and more patients with chronic kidney disease had an undetermined death compared with a determined cause of death. I think that the bottom row here is what is perhaps most striking, is that this is days from enrollment to death amongst patients that died. So 521 days in patients with undetermined cause of death, a median 521 days, versus 396 days, so a very significant p-value there. So the longer we have to follow somebody, the more likely we are to not know why they died. This is a multivariable model, and this is somewhat busy, so I'll walk you through it here. But what you see is the odds ratio for these different variables having undetermined death as opposed to a determined cause of death. And walking down, you see that years from randomization to death per 1 increase associated with a 21% increased likelihood of undetermined cause of death. Enrollment in Australia, Oceania, or South Africa, or Western Europe compared with the United States associated with a lower likelihood of undetermined cause of death. Sorry, North America associated with a lower likelihood of undetermined cause of death. Age had a small effect, a 1% increase in likelihood of undetermined cause of death per 5-year increase in age. 19% increase in the likelihood of undetermined cause of death for every year increase in publication year since 2009. Female sex, 16% increase in likelihood of undetermined cause of death, and enrollment in a coronary disease, enrollment in a stable atherosclerosis or a diabetes trial compared with an ACS trial associated with a lower likelihood of undetermined cause of death. So to kind of summarize what we found that 16% of deaths in this series of well-run clinical trials were ultimately due to undetermined causes. Patient and trial level factors associated with an increased likelihood of undetermined cause of death included older age, female sex, greater time from enrollment to death, enrollment in North America versus Western Europe and a few other places, enrollment in an ACS or AFib trial compared with the diabetes or stable atherosclerosis trial, and enrollment in a more recent clinical trial that we've conducted here. So when we think about deaths due to undetermined cause, I think it's important to think about why a death might be due to undetermined cause. And we kind of broke these out into undeterminable causes and potentially determinable causes. So the patient that dies at home alone with no contact with family or friends, and they're just found dead, that's a patient that has a death of undeterminable cause. And the increased likelihood of undetermined death amongst women and older adults in our population may suggest that these are patients that, these patients are more likely to live alone. Those groups are more likely to live alone. Then you get to the potentially determinable cause of death. And this is when a patient dies, and study investigators can get in contact with friends or family, but friends and family don't want to speak with the patients, with the trial investigators. Or in certain countries, there are regulations concerning sharing of data for deceased patients. And this perhaps is where we see greater likelihood of undetermined cause of death in patients that had a longer time from enrollment to death because their social networks might have changed over time. And in certain countries, seeing a greater likelihood of undetermined cause of death because these countries might have different rules about sharing data. And when we think about what effect how to judge what an undetermined death might mean for how well a trial is run, the first category is you can't really get around that. Those patients are going to have, it doesn't really reflect on trial conduct. But the second category is an area where we could potentially judge a trial based on how many of its patients, how many undetermined but determinable deaths that it has. So why does undetermined cause of death matter? Some undetermined deaths are likely to be due to non-cardiovascular causes. We looked at the proportion of deaths due to cardiovascular and non-cardiovascular causes, and a substantial portion of deaths were non-cardiovascular when we knew the cause, so you assume that many of the undetermined deaths were also due to non-cardiovascular causes. But when we analyze these deaths and we lump them all together, we may be adding statistical noise because the treatment shouldn't affect non-cardiovascular death as much as it affects cardiovascular death. That may obscure signal and lead toward bias towards the null. And this is going to lead to us having a greater likelihood of type 2 error or a false negative in a superiority trial, or type 1 error or false positive in a non-inferiority trial. And that's why the FDA has been particularly interested in these deaths of undetermined cause. So there are some limitations to our work. These are deaths adjudicated by a single CEC, the DCRI CEC. We do a good job. We assiduously seek source documentation. These are well-run clinical trials, but it is one group. When we looked at publicly available information on cause of death, our results were similar to what you can find in other trials. And also, we don't know the reasons that cause of death could not be adjudicated. We can't distinguish between undetermined and undeterminable. And so we can't really say definitively what the baseline is for how many deaths must be, or how many deaths should you expect have to be undetermined in a clinical trial. So in summary, I think we can make some recommendations about where to go from here. So undetermined deaths may be a marker of trial quality, but some are unavoidable, as we said. They should be carefully considered in clinical trial reporting. So investigators should routinely report the proportion of undetermined deaths. They should prospectively collect and report reasons that cause of death could not be determined. And they should consider sensitivity analyses to determine the effects of undetermined cause of death on clinical trial results. And from an operations standpoint, it's important to think about ways that we can potentially reduce undetermined cause of death. And this could involve communicating with patients and their families about the need to contact them should the patient die, having some sort of living will within the clinical trial about who to contact. Better communicating with foreign countries about how to circumvent or overcome or better communicate some of these regulations about obtaining cause of death. And then also just thinking about involving families more in the clinical trial process so that the first time that we contact them isn't, hey, your loved one's died, we need to know what happened. So thank you all, and thank you to the folks from the CDC that made this work possible.
So Alex, that was terrific. Thank you so much for that talk. I have two quick questions. One is, why do you think the publication year mattered so much? And the second question is, as we sort of transition more towards a patient-centered approach to clinical research, do you think patients care about the cause of death, and how should that play into sort of trial design?
Yeah. I think the first question is a really hard one, and I think that one of the other limitations that we didn't really discuss is that these are 9 trials conducted at a single institution. It's possible that we just, got unlucky as time went on. The other possibility is that the definitions that we used for undetermined death and sudden death may have changed a bit. But I think that I don't have a great answer for that question. And the second question, what was the second question again?
Just as we transition to more of a sort of patient-centered approach to clinical research, do you think patients care about the cause of death or just that they're dying, and how should that influence the way that we design trial endpoints?
Yeah. So I think that incorporating a cause-specific death into a clinical trial is somewhat artificial. Like you said, I think that there is some literature about cause of death and good deaths and things like that. But I think that for the most part, patients don't really care whether they die of cardiovascular, non-cardiovascular, or undetermined causes. And I think but on the other hand, all-cause mortality is subject to a lot of noise, and you can, by using cause-specific mortality, you can potentially decrease the number of patients that you're enrolling and really understand that you're targeting your intervention to an endpoint that you can change. But I do think that as we start thinking about how to design clinical trials in a patient-centered manner, thinking about the limitations of our traditional endpoints like cardiovascular mortality is an important thing to do, and thinking about their weaknesses. And one of the weaknesses is that you don't always know why someone died. Even in the best of circumstances, it's hard to separate out why they died, even with all the data sometimes. So.
Alluded to other countries potentially doing a better job at figuring out what the cause of death is. For those of us who aren't as close to it, are there other specific countries who determine cause of death in a different way from the U.S. that makes that easier to determine?
Yeah. So one of the things that I should clarify is all the cause of death was determined in the U.S. So we all of the actual adjudication was done by the group at the DCRI. It's just the quality of the records that you get to help you distinguish, to look at and help distinguish why they died. And some of it might do with cultural factors. Perhaps it's easier to contact family in some countries. Some of it might have to do with likelihood of doing autopsies in various countries. But I think that, and then some of it has to do with the regulations around data sharing. I think that we don't really have the granularity in this data to provide a definitive answer about questions like that.
Is there a top country that provides some really great data?
That's a good question. We didn't look at it by country. We only looked at it by region. And again, we saw that Western Europe kind of did the best amongst countries that had a large number of patients. Yeah.
As you probably remember from being a house staff, you at least unless it's changed dramatically recently, receive incredibly little instruction. So as a CEC, you only have your source documents. If your source documents aren't very granular, then you're not going to be able to do much better. And I just feel that you would get this piece of paper for a patient you barely knew because you were on call, or a clinic patient you hadn't seen in 2 years. And you're given no instruction and not a lot of supervision, and of course they need it back, fairly quickly. So I think, probably some of the problem begins even with our source documentation, even for people who are in the hospital at the time of their death or had recently been in the hospital.
Yeah, I think that that's true, and that we're only as good as the source documents that we have. On the other hand, when we use standardized event definitions, we can do somewhat better. So sudden cardiac death, in most of our trials just means the patient was seen well within 24 hours prior to death. So you don't have to be. It's a little bit different. It's a little bit different a question when you see someone in the hospital and they're asking you why they died, because you can sometimes apply the standardized event definitions. But I agree, it's possible that when a patient is hospitalized for a long time and had a series of procedures and the documentation is spotty, trying to figure out what actually led to their death is sometimes a challenge.
So I think you described the limitations well, having done CEC for a long time. I would like to add that the differentiation into cardiac, non-cardiac is not going to go away. because therapies are designed to prevent certain types of death or outcomes. And it is important for us to know that. For example, you expect in an ICD trial to prevent all sudden death or related cardiovascular death, but if you see all the ICD trial results, there are a lot of non-cardiovascular deaths in them. And so rather than looking at the glass half empty, I would say take the positive out of it. The ones that we are able to adjudicate as cardiac and non-cardiac deaths, it gives us a lot of kind of important information as to whether the drug for to prevent an outcome that is designed for it, whether it is able to achieve that or not. So I think that that is the thing. I mean, I don't think that we will be able to adjudicate 100% of the death in any clinical trials.
Yeah, that's a good point. I think that we've seen in kind of recent, just as recently as ACC, you know, some of these trials where, you know, the trial therapies that should have affected cardiovascular endpoints didn't affect cardiovascular death, but did affect all-cause death, and it becomes a challenge to interpret. So understanding why patients died is always going to be important, understanding mechanisms by which therapies can benefit patients.
Do you see an application for this to speak to the quality of the adjudication that was done?
I think so. I think that there is. There's some. I think that's part of the reason that we did this is to say that you know this is the benchmark. If you have many more than 16% undetermined cause of death, then it's a red flag, and it's potentially, you know, it's possible that you can explain away that red flag. You know, this is why we had a bunch of patients that died, and we don't know why. Is it the way we define undetermined death? Is it the way we define cardiovascular death? But I do think that this is potentially a marker of trial quality. I think it would be a better marker of trial quality if we knew why we had deaths of undetermined cause. So if we were able to prospectively collect, you know, how many times did we call the family? What did the family say when we talked to them? And we could really get into some granular detail about what we tried to do to get in touch with families after patients died and to get records. So I think it's a potential marker, and I think we could make it a better marker with a little bit more work.
So if I'm an industry sponsor, new lead compound in cardiovascular disease, and I want to get an accurate read, that might be relevant.
I think so. I think that if you look at kind of the FDA briefing documents for empagliflozin, the EMPA-REG outcomes had a particularly high proportion of undetermined cause of deaths, and they talked about it a lot in the FDA briefing documents. So I think that it's important to regulators, and I think that, you know, when you think about markers of trial quality, I think it's a potential thing that one would consider. Yeah.
Do you see a relationship between age at entry and the proportion of deaths that were indeterminate cause?
So there was. So every 5-year increase age at entry was associated with a 1% increased likelihood of undetermined cause of death. We didn't see that actually on univariable analysis, but when on multivariable analysis, we did see that.
Great job, Alex. All right, and now our final presenter. I have the privilege of presenting one of our rockstar DCRI Fellows, Dr. Rymer. Dr. Rymer came to us after doing medical school at Vanderbilt. She came to Duke for internal medicine residency, where she served as the chief resident and is currently in the midst of her cardiology fellowship. She's passionate about post-acute coronary syndrome processes of care, and will be presenting to us about some nuances about post-heart attack adherence policies.
Those are two tough acts to follow, but thank you all for the opportunity. So I, as well, got to present at ACC. This was a poster that I then turned into slides. Primary mentorship for this project was Dr. Tracy Wong, and then I had several other wonderful collaborators at AstraZeneca, for which I worked with on the Symphony Health Claims data set. So the question here, and what I'm going to talk a little bit about this afternoon, is differences in 12-month medication adherence based on whether you're discharged on 30-day versus 90-day prescription fill in the acute MI population. This is a simple question, but I think a really important question about how we manage patients with a very common presentation. So let's just start off with a little bit of background. So this is what's known. Our medication adherence rates for our EBMs are evidence-based medications. So these are like your statins, your P2Y12 inhibitors, your beta blockers, are extraordinarily low at the 6-month mark, but particularly at the 12-month mark after discharge. And we know that patients with lower EBM adherence have poor outcomes. So they have a higher readmission risk, they have lower event-free survival than those patients who are adherent. So that's our background going into asking these questions. And our hypothesis was that 90-day prescription fills would be associated with greater or increased medication adherence at the 12-month mark. And then we hypothesized, however, that most health systems are currently discharging patients on 30-day fills. Our second hypothesis, I think equally as important, is that relatively few patients have EBM drug changes who are getting either 30-day or 90-day fills. And this is important because I think a lot of the reason why providers are hesitant to give out 90-day fills at discharge is because there's the concern that there's going to be changes in medication, so patients discharged on the potent ticagrelor may need to switch over to clopidogrel if they have bleeding, or there may need to be titration of their beta blocker or changes in their statin if they have myalgias or muscle aches. So in order to look at this, we used the following methods. We examined MI patients in the NCDR Action and CathPCI registry, and then linked them to Symphony Health Claims data. Symphony is a robust health claims data set with millions of patients, so we have great information on their prescription fill data. And we looked at the 12-month rates of EBM adherence between patients filling a 30-day supply versus a 90-day supply for the following drug classes. Adherence was defined as per usual, so greater than 80% proportion of days covered after the index MI or after discharge from the index MI. And then we also looked at within class changes between those patients who got a 30-day or 90-day fill. And so that means both dosing changes and actual product switches. So here's our population. I apologize, this is a little busy. So we started off with 1.1 million patients. We excluded some obvious subpopulations. Those patients who died within the first 90 days went to a skilled nursing facility. Those patients who didn't have any activity, pharmacy activity, 90 days prior to their admission and then 12 months after discharge. Those patients who had multiple days supply across multiple drug classes, and then those patients who didn't have stable pharmacy visits. And we had a little bit over 308,000 patients. So I want to point out a couple of interesting and important points from this particular slide. So this is our final study population. For prescribed at discharge, and this follows what a lot of our other models and secondary analysis from NCDR have shown, is that we're still not doing a great job at just discharging patients on evidence-based medications. So just nearly a half get an ACE or an ARB. Many will say, well, there's contraindications, and that's why they didn't get those medications, but still 50% not going out on an ACE or an ARB. And then you can see around 75% for the other drug classes. So you can see that the minority of patients were filling a 90-day supply, so anywhere between 10 to 15% for the various drug classes. 30-day supply was clearly the majority of patients. To look at the baseline characteristics, I want to point out a couple of key points here. So patients filling a 90-day supply were typically older. They had more comorbidities, so that ranged from increased hypertension or more likely to have hypertension, prior history of MI, heart failure, CABG, PCI. So essentially more comorbid older patients were getting 90-day fills. Patients who presented with STEMI were more likely to have a 30-day fill, and those treated with drug-eluting stents roughly similar numerically. So let's look at the 12-month adherence rates. So you can see across drug classes, whether it be a statin, an ACE inhibitor, a P2Y12 inhibitor, or a beta blocker, a 90-day supply was associated with significant improvement in 12-month adherence rates. I've also listed the adjusted relative risk below for the 30-day to 90-day. This same trend followed for our 6-month rates as well. You can see a significant difference with all drug classes for those getting 90-day versus 30-day supply. And then I think here's the important point, because everyone's going to come back and say, well, of course, they've got more drug. They don't have to go back to their pharmacy. They don't have to refill. But can I really send a patient home with a 90-day fill when it may just cost them more money if then that medication changes? So one of the things I want to point out, so this was for product switches. So this is if you got sent home with ticagrelor and you switched to clopidogrel, or you sent home with your beta blocker carvedilol and went to metoprolol. You can really see that the minority of patients still with a 30-day fill are switching at any point during that 12-month period of time. A little bit more changes within the beta blocker, which I think most of us who titrate patients on the outpatient setting understand why. But within the 90-day fill as well, you see that the minority of patients really switching from one product to the other. And if you further look at this by how many switches, it's really just one switch that you're seeing within that 12-month period of time. Saw the same relationship for dosing changes. So this is looking at if you're titrating up these antihypertensives like your ACE inhibitors or your beta blockers. Really, the minority of patients, with the exception of your ACE inhibitors and ARBs, are undergoing any sort of dosing change after the index MI. So several limitations that I think that are really important to discuss. As I mentioned, there were about 40,000 patients who had both 30-day and 90-day fills, so those had to be excluded. That's a population I can't analyze. There's many hospitals, particularly with P2Y12 inhibitors, that will send out patients with a supply at the index discharge to try to help with medication adherence. We're not going to capture those patients in this analysis. And then because this is an observational study, there's residual confounding. So important conclusions. So most patients are discharged on and fill 30-day prescriptions according to this analysis rather than 90-day prescriptions. Those patients who went out on 90 days had higher adherence at 1 year and 6 months. And most importantly, though there was a significant difference between product switches and dosing changes between the 30-day and 90-day fills, there was still a minority of patients that were having either a dosing change or a product switch for even those that were discharged on 30-day supplies. So what are the implications to take home here? I think particularly all of us have taken care of those high-risk population of patients. They have poor access to medical care. When they go home, they don't have a lot of transportation. And you know that perhaps their health literacy is not the best. These are the patients in particular maybe to consider a 90-day prescription for P2Y12 inhibitors in particular. So we saw that with the beta blockers and the ACE inhibitors, there's a greater need to titrate them as an outpatient. But I think particularly within that P2Y12 and statin EBM drug classes, this should be considered. And so with that, I'll take any questions.
I think Raj wants to start off.
Oh.
Sorry.
He's pulling it away.
This is very fascinating, but there is one caveat to what you have presented. Mm-hmm. So in my practice, I can only write for 30-day prescription for private insurance because they want to collect the copay. So there is like $80 copay on ticagrelor. Right. Even for beta blockers, it's like $10 copay when I can get a beta blocker for a month for $4 if I didn't have an insurance. Because I have Blue Cross Blue Shield, I will be paying $10 copay for that. Right. So the insurers, they make us write only 30 days. Even if we write 90 days, they're only going to fill for that day. So it is not, and as you saw, the older people are more likely to adhere because Medicare patients, generally, you don't write fancy prescriptions. You stick to clopidogrel, you stick to the generic beta blockers, you stick to the generic statin, whereas you have a leeway in the younger patients because they have private insurance. Right. The other portion of this is the younger patients are more likely not to have insurance. And so that is also, and your data is not able to kind of tease that out,
Sure.
But I think it's it's a question that, should open eyes of at least the private insurers.
Right. I think you bring up a very good point. I don't think all commercial insurers don't allow for 90 days, but I think that's certainly an issue. I think one of the other interesting areas is within the VA population. So I got a lot of traffic actually from VA pharmacists during ACC, and as you know, probably all of their post-MI patients go out on 90-day fills. So all patients are discharged on 90-day prescriptions there. And really there's a cap at around $7 to $8 for these 90-day prescriptions. And there's going to be a paper by Stephen Waldo out in a couple of weeks in Circ Intervention showing just how much better their medication adherence rates post-MI are than a lot of our patients in systems like Duke. And I think part of that is because of this 90-day fill, but also part of it is because they're sort of capped how much it costs for the patient. I do think that hopefully this data and other similar studies are seen by many of these insurers, and potentially with the potential cost savings with readmissions being avoided, it's considered to allow for more 90-day prescriptions at the end of an MI admission.
If the patients that are on the 90-day, how many of them are on mail order? Because mail order waives the copay, or it's a nominal copay.
We are specifically looking at that. So I didn't show the entire analysis, but we're specifically going to look at the various forms of pharmacy and see what the breakout of that is as well. That's a very good point. Thank you, guys.
Does the group have any other questions for our three panelists here? All right, with that, I'll bid adieu. Thank you, everyone, for your attendance.